Okay, Bill, the next question is whether or not kids would have wider upper and lower jaws and therefore a wider airway if they were not to wear fixed retainers before growth was done.
Okay. I'm not a big fan of any type of fixed retention. It's very common, and I used to do it all the time with what is known as a 3-to-3 retainer on the lower arch. But for this year, will make 30 years I've not done that. The reason is, 30 years ago, I met an orthodontist who was violating all the rules of, we were taught never to expand the cuspid width. The lower cuspid width was supposedly inviolate. We shouldn't expand it. But he was doing it all the time, and I saw that the smiles looked much better, and I decided that I was going to do it, and it worked for him, and I've been doing it now for 30 years. Smiles are wonderful. The width is much wider, and I don't like to see anyone have some kind of fixed retention. That gets into some temporomandibular joint implications and cranial osteopathy and stuff that well beyond an interview like this. The fact is, most of the patients that we see have very narrow upper and lower jaws to begin with. And the last thing we want to do is to keep them restrained in a narrow arch. We want them to have a nice broad arch. Most of them will have an intermolar width of somewhere in the between 30 and 35 millimeters probably. Ideally, we would want to see the width more than 40 millimeters. My mentor in England, John Mew, talks about needing to have 42 millimeters of intermolar width if you're going to have the tongue able to be at the palate. What we want is the tongue to the palate, completely to the palate, with the patient have their teeth lightly together, with their lips together, breathing through their nose. If they do that, they're going to grow forward normally, and they're not going to likely be the patient who's got sleep apnea. So any form of restrictive retention like that, I'm not in favor of. And so instead of doing that kind of thing, the profession ought to be addressing the narrowness of the arches, expanding them laterally, and more than that, developing them forward, which is the real key. The exact opposite of what is traditionally done is what needs to be done. In all malocclusions, the first thing that happens is that the upper front teeth fall down and back, whether it's class 1, class 2, or class 3 that we orthodontists use to classify. That classification system is actually very useless, and it really gets in the way of us. Because you say if someone's class 3, oh, the lower jaw is too far forward. No, it isn't too far forward. Most of the time it's too far back. And so the last thing we want to do is be moving the lower jaw back in those, quote, class 3 cases. We want to see the jaw moves forward in all the cases. If you compare us to Paleolithic man, our upper and lower jaws are back by several millimeters. I'm talking, half a centimeter, at least 5, maybe even close to a centimeter probably, than what it was back that many years ago. Those people, we have no reason to believe that they had to have CPAP machines in Paleolithic times to stay alive. If they had sleep apnea, surely they would have died out and we wouldn't be here. Trouble is now here we are, we're all struggling because our jaws are back, our soft palates are back, and our tongues are back, and the airway is compromised. As the smaller the airway is, it's more likely going to collapse. It's like the Bernoulli principle where an airplane flies, a curved surface with a rapidly flowing air gets a negative pressure. So that's what happens to the soft palate and or the tongue. The smaller the airway is, the faster the air has to flow. The negative pressure causes the soft palate to fall back or the tongue to fall back, seal off, and then you have sleep apnea with all the things that go along with that. We should be really concerned about this, particularly, the pediatricians should be screening for this. The pediatric dentists are in the front lines of this. They should be screening for all of this because we know that we're seeing a child who has sleep apnea, even in one night, is getting brain damage. Ron Harper at UCLA, as a PhD neurobiologist, talks about this very graphically, showing the areas of the brain where in even one night you have permanent damage to the brain. Now, what does that do to the child in the future? Nothing good. And we have kids who are going to first grade and probably never going to reach the potential. They'll be struggling even to read.
Wow. Okay, I'm gonna pause the recording and we'll go to the next question.